So again, I'm giving this on behalf of Dr. Finelli. These are his disclosures. So when you talk about building an algorithm, in terms of probably any treatment, but we'll stick with the topic here, you always want to keep track of the patient. So, what's their clinical status? And a lot of times we don't really take into consideration their lifestyle, and really sometimes we don't take into consideration life expectancy. So I think that's always good to think about. In terms of the actual technical stuff, lesion type and complexity, obviously you want to take into consideration. And then there's always going to be a variety of treatment options. And I think it's imperative that you understand the evidence behind those treatment options. And then always, when you pull out a device, understand the indications and contraindications to the device. And then, particularly in the United States, I think we also have to be mindful of reimbursement in terms of using devices all the time, especially if they're not reimbursed. So in terms of angioplasty and calcific lesions, there's different mechanisms by which flow-limiting dissection occurs, and it basically follows the pattern of the balloon. So it could happen because of a twist, it can happen because of radial stress from overexpansion, and it could happen in more of a tear or spiral fashion with elongation of the vessel. So drug-eluting era, so we need to vessel prep for drug-coated devices and drug-eluting devices. So how do we, why do we do that? Well, to increase the drug uptake. We want to increase the chances of successful vessel scaffolding or stenting with the DES. And we obviously want to lead to improved patient outcomes. So I think everyone's probably seen this slide. Dr. Finelli's done some fantastic work in calcium, and you see this graph that looks at calcification by quadrant, and you see that obviously the more quadrants that are calcified, the lower primary patency you can expect, particularly at 12 months. In terms of vessel prep for DES, it's a similar concept. You need to get the scaffold or stent and drug to the location where it's going to work, so you need to prep the vessel so you get optimal expansion of the stent without any asymmetry. And this can happen with a variety of different equipment. So sometimes just a plain old balloon works. Sometimes specialty balloons can be advantageous. Sometimes you need Kevlar balloons, whatever it takes to get the vessel prepped. And then oftentimes, especially with calcium, atherectomy devices and now lithoplasty become viable options. And all of these are used so that you improve the acute outcome and you increase the lumen gain, get the biggest area you possibly can so that you can actually get the drug to where it needs to be. So here's his algorithm. You have a severely calcified lesion. He advocates scoring balloons and atherectomy, which I think we would all agree with as well. So you initially try that. If you've got a nice residual stenosis, then you can move on to a DCB. If you have a nice result from that, then you'll be okay. If you don't, then stenting obviously can be needed. If you go down the DCB arm again and you have a less than 50% residual stenosis, you can probably call it a day, particularly if there's no flow limitation. If you do have flow limitation, then you can repeat the dilatation. If you still have a little bit of residual, you can repeat again, and then obviously spot stenting can be helpful if there's a persistent residual stenosis. So here's a case that he had with a very low ABI, grade 4B type disease. Here's the angiography. So you see heavy calcification with maybe 2 vessel runoff, 1.5. And so in this particular instance, atherectomy can be very useful. You see by IVUS, very nice job of debulking and opening up the vessel, which then leads to full expansion of the drug-coated balloon, which is what you want. You see here that you have most of it's okay, but there still is a problematic area. So repeat PTA with continued problems. So scaffold was placed and a pretty decent result considering what he started with. 12-month follow-up, still patent. So nice result. In terms of stent threshold, smaller diameter vessels, long lengths, and low calcium, you kind of want to stick with DCBs. If you have heavy calcium, larger diameter, and you debulk, those are places where stents are going to work a little bit better, mainly with the larger diameter vessels. So in conclusion, calcifications obviously present a great limitation to our SFA procedures, but if you adequately debulk with whatever equipment you need, you'll get a better biologic effect of your drug-coated therapy, and hopefully that leads to improve patency rate long term. Thank you very much.